and I'm a physician trained in internal medicine and psychiatry, and I could talk about sleep disorders, which are kind of at the intersection of psychiatry, medicine, and neurology. So here we go. There.
Can you advance the slide? Just click on the arrow key.
Yeah,
or
there's a warning in the middle of my slides about recording. Let me try to take that off. Yeah, kind of in the middle of the slide. Hold on.
Just move it to the side.
I did, yeah. No, I don't.
Go to the bottom. You'll see a little left and right arrows. Click on the little right arrow on the slide, and that'll take it to the lower left-hand corner for the presentation.
Yeah. It doesn't seem to work, unfortunately. Oh, let me see.
I'll advance the slide for you. Just tell me next.
Okay. All right. There we go. So this is how the presentation is going to be structured. Talk a little bit about what normal sleep is, then a brief overview of the various sleep disorders organized in diagnostic categories as they think about them now, and then stop a little more on insomnia and obstructive sleep apnea, which are the two sleep disorders that are probably the most common and significant in terms of impact. Yeah, next slide, please. Meanwhile, we're going to talk a little bit about what happens with people with mental health conditions and substance use disorders. So why do we need sleep? That seems like an obvious question, but surprisingly, it doesn't have obvious answers. The scientists have been debating as to why we have evolved to even need sleep, as animals are obviously at a disadvantage when they sleep, as they are prone to predators. So why do we as humans need to sleep? Well, a few answers to that, without any one answer being the absolute. It seems that it plays a role in energy conservation, as we do use less energy when we sleep. There are a number of processes that occur during sleep only, such as muscle growth, tissue repair, production of certain proteins, production of growth hormone. So there seems to be a role in achieving growth and repair. Sleep helps us clear drowsiness, excuse me, and increase alertness. And sleep is correlated to changes in the structure and organization of the brain, as it's been shown on some functional imaging, suggesting that there is indeed a role in learning and the role in consolidating memories. Oh, next slide, please, Carl. Now, how does it happen that we sleep? What processes are involved? First of all, there is the 24-hour body clock, the circadian rhythm, and that responds to cues from the environment, such as light and darkness, that through biological processes tell us to be alert or tell us to be drowsy. While awake, the level of adenosine in the brain keeps rising. So that's a substance that is simply produced by being alert. And it accumulates and makes us more drowsy the more time goes by that we're not sleeping. During sleep, the body breaks down the adenosine. And by the way, coffee clears the adenosine too. So sleep and coffee make us more alert. The body releases various chemicals in a daily rhythm that is controlled by this body clock. When it gets dark, the body releases melatonin, and the melatonin signals the body that it's time to prepare for sleep, and it helps the drowsy. Exposure to bright light in the evening can disrupt this process and makes it hard to fall asleep. For example, light from a TV screen, computer screen, and so forth can disrupt the production of melatonin and increase alertness at night. This is also good to know because bright light therapy can be a treatment for when people are drowsy when they need to be alert. So like during the day for various reasons, if people are not alert, exposure to bright light helps that. As the sun rises, the body releases cortisol, which is a hormone that produces more energy and prepares the body to wake up. Next slide, please, Carl. So what is healthy sleep? There's a lot of variation, but in general, it's considered that in adults, 7 to 9 hours sleep are, that's the normal duration. There are rarely, but there are people who need less sleep than that, and they're perfectly alert, and it's probably they have a little bit of genetic variation and are lucky that way because they don't have any problems with sleeping less than others. But in general, sleeping less than 5 hours consistently or more than 10 hours makes people have poor health and even increases mortality. Now, timing of sleep is important too, because sleep should follow the circadian rhythm, and sleep during the day does not seem to have the same benefit as sleep during the night. Naps have been debated, are they beneficial or not? And the answer seems to be that short naps, such as 30-minute naps, are actually beneficial and increase the state of health and prolonged life. Weekend sleep has also been debated. It seems that on one hand, weekend sleep does make up for some sleep deprivation, so it's okay to sleep longer. But if this sleeping longer is really excessive and people spend most of the weekend in bed, that actually is not helpful, and that perpetuates the sleep problem too. Next slide, please. Sleep stages, just a brief overview because we'll refer to this briefly. If an EEG is recorded, an electroencephalogram, which records brain waves during sleep, everybody exhibits this pattern. These are what you see there in the picture are brain waves, and people in the light sleep have certain brain waves in stage 1 when they're just lightly asleep, and then as they progress, stage 2 and stage 3, their brain wave changes, and what changes too is the sleep gets deeper, their muscles get more relaxed, there's less and less movement. And then finally, in the last stage, which is the REM sleep, the wave changes, the waves change again, and that corresponds with a state when the muscles are effectively in a state of paralysis. They just don't have any reflexes, they don't respond at all. And but what moves is the eyes. So the muscles that move the eyes behind the eyelids are moving, and they're moving rapidly, and that's why this is called the rapid eye movement stage. And this is when dreams occur. So, so there is the non-REM sleep, the first 3 stages, and then the REM sleep. And there are various disorders that occur in various stages of sleep, essentially either in the non-REM sleep or in the REM sleep. Next slide, please. So what is sleep deprivation? I mean, we know what sleep deprivation is. And most common cause is that people don't have time to sleep. Social, family, work obligation make it such that people don't sleep enough. And then when people are sleep deprived on a chronic basis, they tend to fall asleep early, they tend to fall asleep deeply and have longer REM stages, and therefore dream more and more vividly, and stay asleep longer, unsurprisingly. So next slide, please. Lots of consequences of chronic poor sleep. In terms of physical health, there was a study that just took healthy youngish volunteers and deprived them of sleep. And even after only a few days, they were showing increased blood pressure, increased appetite, a tendency to gain weight, increased blood sugar, and signs of inflammation. It has been shown that chronic poor sleep is linked to hypertension, diabetes, and obesity, to a decreased state of immunity, and therefore more infections and more rheumatological diseases, and an overall increased risk of cardiovascular disease. Even more dramatically, maybe, poor sleep is associated with poor performance, motor vehicle crashes, and human errors. Next slide, please. While in terms of mental health, even if there's no clear condition that occurs with poor sleep, sleep deprivation is associated with just a state of low optimism and sociability, with a state of depression, anxiety, irritability, mental exhaustion, and low concentration. And in fact, probably the most common cause of decreased focus is not ADHD, but it is poor sleep. Poor sleep is also a motivator of substance abuse because people tend to want to use substances to resolve the problem. It's also, of course, a consequence of substance abuse. And then when people have underlying conditions or underlying vulnerabilities for conditions, those get worse. So in people with psychosis, sleep deprivation is associated with worse psychosis. In people with bipolar disorder, even slight sleep deprivation can trigger mania. We've seen people with as little as one night of missed sleep triggers mania. And sleep deprivation is clearly a symptom as well as a factor in exacerbating depression and anxiety disorders. Next slide, please. And as you can see, it's expensive. Sleep disorders are expensive to the society. They are somewhere in the middle of this graph. Next slide, please. So what are the sleep disorders? As I mentioned, sleep disorders are somewhere at the interaction between psychiatry, neurology, and medicine. The DSM-4 is the diagnostic and statistical manual used in psychiatry. The every expert meets every few years to review the evidence and see whether the diagnostic categories they came up with are still true, whether there's evidence of any new conditions that were not recognized before, or whether some conditions are actually part of another condition and they're not separate, and so forth. So this is a newest version. It changes a little bit from one time to another because there rarely is an absolute test to identify the disorder. It is, of course, as in most psychiatry, just a clinical diagnosis. But insomnia disorders are the most common. There are a group of disorders that are called hypersomnolence, when people sleep too much, narcolepsy, circadian rhythm or sleep-wake disorders, parasomnias, which are different disorders that occur in the stages of sleep, either non-REM or REM, restless leg syndrome, excuse me, and breathing-related sleep disorders. So we'll talk in more detail about the first one and the last one, the insomnia and the breathing-related sleep disorders. But first, we'll do a quick overview just to understand kind of what the other ones are like. Next slide, please. So how does it look when someone has a hypersomnolence disorder? This is not common. This is maybe 1% of the population. But what that means is that essentially people sleep a lot and they wake up unrefreshed. And even more, they have naps during the day, maybe even several naps a day, and they still have no improved alertness. And furthermore, if somebody tries to wake them up from sleep, they really have difficulty being fully awake. They are unable to be fully awake. And that maybe is the most specific symptom of this hypersomnolence. Stress and alcohol can produce syndrome like this, but this syndrome has been described after viral infections, after head trauma, and even in certain genetic syndromes. Next slide, please. Narcolepsy is also a hypersomnolence disorder, and that's characterized by an irrepressible need to sleep. People fall asleep in the middle of their activity, whether they're standing up or driving. And sometimes that's associated with cataplexy, which is a loss of muscle tone when laughing, joking, or having an intense emotion. So people literally fall down laughing. And if you record a sleep study, that shows that people have this REM sleep that occurs suddenly. So instead of going through the non-REM sleep stages first, they go directly into REM. I have to apologize to the audience. I really have to get a glass of water. I'm really sorry. I have to interrupt for 1 second. I'm sorry. Let's go to the next slide, please. Sleep-wake disorders. So there are several sleep-wake disorders, and one of the most typical one is the shift work inducing sleep disorders. So when people have to work at night and sleep during the day, they often have resulting sleep problems. They cannot sleep during the day, and then they're asleep at night and they are seriously sleep deprived. Delayed phase sleep is something that is normal essentially in adolescents, but it's not normal in adults. Adolescents have, it's a normal process for them to produce melatonin later than adults, and then they tend to be alert for later and go to bed later and wake up later. It's just a physiological process for them. But in adults, it's not considered normal. And when people go to bed after midnight, let's say, and they wake up at noon the next day, and they cannot snap out of it despite correcting their habits, it's a delayed phase sleep disorder. It appears from some studies that up to 50% of people with schizophrenia may have a delayed phase sleep disorder. And another sleep-wake disorder is jet lag. That may be anybody is subject to that. Some people more than others. Next slide, please. Parasomnia. So these are the disorders that occur during various stages of sleep. So on the left, I have this tiny vignette that this person had nights when he appeared to be awake and screaming. He could not be consoled and would not remember it the next day. So people appear as if they're awake. They may get out of bed, and they cry and scream and appear to have a terrible time, but they do not respond to any attempts to console them. You're not sure whether they hear you or not. And then they end up, maybe after 15 minutes or less, they end up going back to sleep, falling asleep, and they don't remember anything the next day. And this is a non-REM sleep disorder that is called sleep terror. It's different from nightmares. In nightmares, people remember what they dreamt. And that nightmares occur during REM sleep, but sleep terrors occur during non-REM sleep. And again, people have complete amnesia as to what happened. Sleepwalking is also non-REM sleep, parasomnia, and sleep-related eating has been described. People wake up and eat, and it's the same thing. They have no idea that it did that, and sometimes others notice it, or they notice that there are signs that they ate the night before, but they're not really aware of it. Nightmares we mentioned, and the REM sleep behavior disorder, that's a pretty significant disorder where people actually have complex activities during the REM sleep that can be very significant. They get up, they can beat up someone, or they can act very bizarre, and they're not actually awake. Next slide, please. Restless legs. Restless legs, that's a disorder where people have an irresistible urge to move their legs. It happens when awake, but when trying to get to sleep or when at rest. And it's described as some kind of a numbness or tingling or pressure in the legs that's intolerable, and that people just have to move their legs to get it better. It can occur for no clear reason, but a very common reason is actually iron deficiency. So sometimes it appears or it gets worse when people are anemic for one reason or another. Other times it can be a side effect to medication, and antipsychotics can produce that. Next slide, please. So finally, insomnia. So this was, I'm sorry about this past review of this disorder. It's a little bit of marathon, but here is insomnia, which is probably the most common sleep disorder. And that means a persistent sleep difficulty, although there is adequate sleep opportunity, and also it's associated with daytime dysfunction. So this is to differentiate from people who sleep little and then there's no impact. Very few people. There is a huge comorbidity to this, as insomnia can be a cause or a symptom of a medical problem, a psychiatric problem, or a neurological problem. There are lots of factors that can play a role, such as acute stress, medications, stimulants, for example, right, or even decongestants over the counter can produce insomnia. Substance use, of course, just poor sleep habits and changes in the sleep environment. And we'll talk a little bit more about those factors. But insomnia can be at the beginning of the night, the middle of the night, or at the end of the night. And it's important to get a really good sleep history and differentiate, find out exactly what happens. Next slide, please. So here's a case. 45-year-old man presents with difficulty falling asleep and staying asleep. The problem started after the death of his sister 3 months previously. He says that he's lying awake for at least an hour after going to bed. He tried his CCP, who prescribed a low-dose amitriptyline, which is an antidepressant, which is sedated, but he had been unable to tolerate it. He has about 4 cups of coffee during the day because he's tired, and then lately he started to drink a couple of drinks at night to help him sleep. That is a very typical presentation. Next slide, please. And here I was going to ask you, the audience, like, what do you think is the cause for this person's sleep difficulty? So would it be easy for you to just write in the chat? What do you think? 1, 2, 3, 4, or 5?
Yes, go ahead and type it in the chat box. And address it to the entire audience, that way we can see.
We'll wait just a second, see if that's possible. If that's too hard, I'll just go on. But Right.
not getting anything in the chat box.
Yeah, yeah. So maybe that it's just hard to do. Sorry, without certain prior knowledge. So, what is the cause for this person's sleep difficulty? Right? Is it the acute stress? I mean, there's definitely has been some acute stress. Is it depression? Is this person depressed? I mean, there's reason to think that that might be the case. Is it that is inadequate sleep hygiene? Right? So the habits around going to bed are not right. Does this person have restless leg syndrome or obstructive sleep apnea? So we don't have really enough information to tell, except the fact that he has acute stress, he drinks a little bit, maybe too much coffee, and that he drinks at night. Let's go to the next slide. So very important in assessing the insomnia, because insomnia can be so many different things. It's very important to take a really good history. So all the details about when do people go to bed, what happens then, how long does it take them to go to sleep, how long do they stay asleep for, if they wake up, how many times they wake up, do they wake up in the early morning, what are their habits around going to bed, what do they do just prior to going to bed, or how does their day look like, and what is their environment, how does their bedroom look like, and what are the conditions in it. You can give people a sleep diary, and that can be very useful many times in diagnosing what's going on, because sometimes it's hard to remember. And when you ask people, well, how many times has it happened this week? Maybe it's a little bit hard to remember. But if they keep a sleep diary for a couple of weeks, that's much more helpful. And the National Sleep Foundation has such sleep diaries. They can just be printed out and self-report. Of course, people can have a sleep study, but that's rarely done in insomnia. Next slide, please. But for example, here's how the sleep diary would look. And these people fill this out themselves. What time do you go to bed last night? 10. What time do you think you fell asleep? Well, maybe midnight. What time do you get up? 6:30. Was that when you were supposed to, earlier than you were supposed to, or later? And let's say in this, for this person, it was when they were supposed to. Early awakenings, at least half an hour before they're supposed to, with inability to go back to sleep, is many times a sign of depression. Did you wake up during your sleep time? And let's say in this case, this person says, yes, I did twice every time I was awake for about half an hour. That's pretty disturbing. So first it takes him a couple of hours to fall asleep, then he wakes up a couple more times. I mean, certainly has a lot of reasons to be very tired the next day. And indeed, when you ask how tired did you feel, he felt very tired the next day. And how much stress have you had the day before? About a 3. So this is helpful when people, and sometimes some sleep diaries have additional details, but filling this out for a couple of weeks in a row just gives us a good idea about what's going on. Next slide, please. So in this case, what kind of interventions could one consider? So certainly there was some brief, maybe on stress, counseling, and support that could be done. The other typical interventions are sleep hygiene, CBT, cognitive behavioral therapy, and some kind of medication. And I think the next slide is about sleep hygiene. Can we see the next one, please? So what is sleep hygiene? So it is being really strict about the rules surrounding sleep, such as you're okay taking naps, but not longer than 30 minutes. Don't drink coffee and don't smoke in the later part of the day. Exercise. Exercise helps a lot with good sleep, but not when it's too late during the day because it can be a stimulant as well. Don't eat lots of spicy, stimulating foods before bedtime because they can produce acid reflux and indigestion, and they can be disruptive to sleep. Ensuring adequate exposure to natural light so that the circadian rhythm falls into place establish a regular, relaxing bedtime routine, whether there's a bath or some kind of relaxation or just something pleasant to do, and making sure that the sleep environment is pleasant. And it's surprising how much detail can make a difference in this sleep environment. And sometimes we have to remind people that comfortable mattress as best possible, and clean sheets and clean wear, and not too noisy, the right temperature, which is on the cool side, and the right amount of darkness, just very little light, and so forth, can make a big difference. And there is this website, sleep.org, bedroom, that has a lot of details about making the sleep environment better. Next slide, please. And then CBT, I mean, what does CBT work on in sleep? Here are a few of the things. And at the bottom, you have a Mayo Clinic site that has more details on this. But one of the main things is called stimulus control therapy, and for its complicated name, all it means is that there has to be an association between bed and sleep. So people essentially are advised in detail to not use the bed for anything else other than sleep. And if they can't sleep after 20 minutes, they should get out of bed and walk around until they feel sleepy again, and then come back to bed, because there's a thought that somewhere this association has been damaged and the brain has to reassociate it. Sleep restriction is along the same line of thought, but lying in bed when awake can become a habit that leads to poor sleep, and then people worry about not sleeping. So more than advising people just to be in bed when sleepy, this restricts the amount of time in bed. So for example, let's say last night the person just slept 4 hours. So tonight, you can recommend that they're only going to be in bed for 3, no matter what. It's hard to do, and sometimes if people have underlying mental health condition, it's a little dangerous, because people can get worse. But if they have good supervision, that can be an effective treatment, because just being allowed to be in bed 3 hours will make them exhausted, but maybe more likely to sleep those 3 hours. And then as those 3 hours become established, they can increase the amount of time that they allow themselves to be in bed. Relaxation training, a lot of methods there for relaxation. Remaining awake, which is just don't try to fall asleep, just let it happen naturally. And biofeedback is another method that teaches people how to control their heart rate and muscle tension and adjust in a way that is conducive to sleep. Next slide, please. It's very important that the medication is non-addictive and doesn't create a habit. So, we all know about the problem with benzodiazepines, which is kind of the same as the problem with opiates and chronic pain, really. People get dependent, they cannot get off them anymore. And it's not necessarily that they sleep better. They sleep temporarily, but not in the long term. Other things, antidepressants, melatonin, hydroxyzine, and other antihistamine like Benadryl, clonidine, which is an all blood pressure medication that helps with anxiety and sleep. Prazosin sometimes is another old blood pressure medication that is used for nightmares and for insomnia. Gabapentin, which is now, there's more and more debate whether that is a good idea because of the increasing reports that it's being abused and so forth. So next slide, please. Okay, case number 2, the sleep apnea. So here is a typical presentation of that. 55-year-old male who comes in just saying that he feels very tired. He has gained some weight over the past 6 months. His wife mentioned that he has trouble concentrating on tasks. she often finds that he has dozed off in front of the TV while waiting for dinner. He has restless sleep and snores loudly. He does little else but sleep during the weekend, and she worries that this might be a sign of depression. He has on occasion fallen asleep during meetings at work, and much to his embarrassment, colleagues nudge him awake when his snoring starts. He goes to bed around 11 p.m., falls asleep quickly, but may wake up several times throughout the night to go to the bathroom. He wakes up at 7 to get ready for work and has to drag himself out of bed. So you see here, so is middle-aged or later adults, men more than women, have gained weight, and people can present with terrible sleepiness and fatigue that looks like they're sick or they're really depressed. Next slide, please. So again, what is this? Is this insomnia? Is this hypersomnia? Is this depression? Are these nightmares or obstructive sleep apnea? And it can be any of those. But in this case, it will be the obstructive sleep apnea, and there are several signs that this might be the case. Go to the next slide, please. So what is obstructive sleep apnea? So if you just look at this blue flow of air that goes through the nose and then gets in the back of the throat and tries to get through the neck down into the lungs. And you can see that at some point in the back of the throat, that flow of air becomes really thin because there are a couple of things that obstruct it. And one is that light pink muscle that is actually the soft palate in the back of the mouth, and the big muscle, which is the tongue. And due to gravity and muscle relaxation and some kind of anatomical conformation during sleep, those fall back and really compress. They fall back in the throat, and there's no room for the air to come in. So every now and then, they obstruct completely, and people just don't breathe for periods of time that go up to a minute. If they don't breathe, obviously they don't get any oxygen. The oxygen concentration in the blood falls, and they can't blow off carbon dioxide. So the carbon dioxide concentration rises, and then finally their breathing kicks in, and they have a strong breath that overcomes this obstruction, and that can be a snoring, a very loud snoring, and also it can wake them up with the sensation of gasping for air. When people spend the whole night with not enough oxygen for a long time and too much carbon dioxide, all their organs are going to suffer. And the accumulation of carbon dioxide makes people tired. This is just a direct effect of the carbon dioxide on the brain. I mean, if you know that when you're in a really crowded room, you may get sleepy and less alert, that's because there's high concentration of carbon dioxide, and that's a direct effect on the brain. And also, the lack of oxygen just leads to additional processes that happen in the heart, the lungs, and the brain that lead to essentially an increased risk for cardiovascular disease. Go on to the next slide, please. So the symptoms, essentially, the symptoms are a lot of sleepiness during the day. So unusual sleepiness during the day. And the fact that people do sleep, but they wake up unrefreshed. Many times they snore. Sometimes their bed partner hears them when they stop breathing. That if they're awake, that can be pretty scary. And then it's been shown more recently that the most sensitive sign that is associated with sleep apnea is this awakening with gasping people describe that. They don't always describe it, but if they do, there's a high likelihood that that's what they have. In addition, they're just restless, they can have insomnia, and then during the day, their memory is impaired, they can't focus, their mood changes, they get headaches in the morning, they can get strange dreams, and they get up to urinate at night just because of the changes in their body processes with the decreased oxygen, increased carbon dioxide. Next slide, please. The sleep apneas, they occur a lot in the general population, but it seems that they occur a lot more in people with schizophrenia, anxiety, depression, and PTSD. So you would say maybe all the mental health disorder, not maybe all, but in schizophrenia, in some studies, it's almost 50% of people with schizophrenia may have a sleep apnea. And you can imagine that the picture is very confusing because then you have someone on antipsychotics, they're very sedated, very tired during the day. Nobody knows if there's like the blunted affect of schizophrenia, negative symptoms, or is it too much antipsychotic, or is it really the sleep apnea and then their memory and their focus is impaired and they never achieve full control of the disease. Very common in opioid use disorders, and there are two kinds of apneas actually in opioid use disorders. One of them is the obstructive sleep apnea, but the other one is what's called central sleep apnea, where literally the breathing center in the brain does not kick in. Normally, it just kicks in every few seconds, right, and we automatically take a breath. But when people have used opioids, that doesn't happen as often. And sometimes that's how people die. Essentially, if they overdose, they just stop breathing. The sleep apnea may mimic a psychiatric illness. So like you saw in this case, his wife thought that maybe he's depressed. And, you know, it's a reasonable thing to think because they act depressed. And when they have a mental health condition, that may influence their adherence to treatment because treatment is a little bit difficult. From the physical perspective, people with sleep apnea have obesity, hypertension, diabetes, heart disease, and stroke. Next slide, please. So diagnosis and treatment. Essentially, you can ask questions that essentially ask people how sleepy they are during the day. And there's this scale that one can download. It's called Epworth that just goes through usual activities and ask people how likely they are to fall asleep. And you'll see an example of that in the next slide. A sleep study is really the way to do it. And so that means that people go to a sleep lab or sometimes now at home too. They get hooked to a number of monitors and their sleep gets recorded, and they can say exactly how many times they stop breathing, what happens with their oxygen, and so forth. And then treatment, weight loss is a treatment, although occasionally people with normal weight will develop it, and that doesn't work. And then CPAP, which is a continuous positive airway pressure, is essentially a mask that pulls the jaw a little bit so that creates more space in the back of the throat, but also pushes air. So even if there's obstruction there, the air will push through. So you can see a picture, I think, maybe on the next couple of slides. So let's see the next slide. So this is Epworth, just FYI. Okay, so this is where it's at. How likely are you to fall asleep when you sit and read, when you watch TV, when you sit in a public place, when you're a passenger in a car, when you lie down to rest, or when you drive? And obviously the severity goes in this order. Next slide, please. This is just a picture of the CPAP. It looks impressive, but the CPAP these days are, you know, smaller and smaller and better tolerated. And the thing is, people may have a lot of resistance to using it, but you know, if they're used right and they have the right parameters, people feel great and their health gets a lot better. So it's really a treatment to advocate for. Sometimes, especially people who have an underlying mental health condition, they get claustrophobic, and they really have to get treatment for that kind of anxiety disorder to be able to tolerate the CPAP. Next slide, please. have a couple more things to say. So kind of looking at all this and what happens when people have a substance use disorder. When people drink, they have a lot of sleep problems. So it's true that alcohol helps them fall asleep, but as alcohol metabolizes and breaks down, it actually wakes people up. So there's increased, people fall asleep easier, but then there's increased fragmentation of sleep. And the obstructive sleep apnea can get worse, maybe because of this effect of muscle relaxation and deep sleep with alcohol. Marijuana increases sleep, decreases REM sleep, and then there is a withdrawal symptom that can be a prolonged sleep disruption. With nicotine, the sleep is shorter. It's kind of a stimulant. Next slide. Of course, with stimulants, there's decreased sleep, and with opioids, a lot of people with opioid use disorder have insomnia. We talked about the central sleep apnea, very common, and then obstructive sleep apnea as well. Next slide, please. People have mental health conditions. So I think we mentioned that the early awakening can be typical for depression. People wake up at 4:22 a.m. and cannot go back to sleep. That can be a sign. People cannot fall asleep when they have ruminating anxiety. In mania, they don't sleep, but also they don't feel like they need to. They still have increased energy the next day, and that goes on for days in a row. Of course, nightmares, especially PTSD, and chronic sleep problems are very common in people who have mental health conditions. Next slide. In schizophrenia, there's insomnia. We mentioned about the delayed phase sleep. A lot of people go to bed later and wake up later. If you record their sleep on a polysomnogram, record the brain waves, they look differently than normal sleep. And the antipsychotics influence that too. So antipsychotics may help people sleep, but they change the architecture of sleep and how the sleep looks like. Very common, obstructive sleep apnea, almost half. Restless leg syndrome is common in people with schizophrenia, and an antipsychotic can make that worse. Next slide, please. So just in conclusion, you know, when there's severe sleep disorders in people with serious mental illness and substance use disorder, overall, it's a really significant problem because their worse outcomes, their course of illness is just worse. The coping is poorer. They just don't have the energy to work on it. They can actually have more adverse drug reactions and cognitive deficits. So it's really important to address that. Let's see, is there another slide? Or is maybe the last one? Oh, and again, just in terms of intervention, it's very important to just talk with people about basic sleep habits. That can help a lot. Bright light therapy, we haven't talked a lot about it, but it can be used, for example, in shift work disorders or in delayed phase sleep. You make people go to bed earlier, and then in the morning they're drowsy, but you give them some bright light, and that helps change their sleep-wake cycle. CPAP, of course, cognitive behavioral therapy. It's important for people to have a personalized sleep plan. There's no one-size-fits-all, because people may need something else depending on what their underlying condition is. I think this was my last slide. Let's see if we have a few minutes for questions. Yeah, thanks, class.
That was your last slide. Great job, Delia. Great job. Very informative.
Thanks very much. Yeah,
Does
questions.
anyone have any questions or comments they'd like to make? You could either type it in the chat box or click on the little raised hand icon, and I could unmute your microphone so you can speak. So we'll give you guys a couple minutes. If you need to type something in or think about any questions you may have. Very informative, Delia. My girlfriend has restless leg syndrome, so that kind of sparked it for me.
Yeah, thanks. No, and again, restless legs sometimes, it's a sign of iron deficiency. Gets better with iron, but obviously there are specific medications that help too.
Yes. Okay. So I don't see any questions coming in, nothing in the chat box. So if there's no further questions, we can go ahead and end the webinar.
Okay, great. Thanks, Carl. Thanks, everybody.
Thank you, everyone.
Bye.
And we'll see you next time.
Okay. Bye-bye.
Right. Have a great day, everybody.
You're welcome. Thanks.